The study, of course, we are seeing a change in landscape of treatment in Alzheimer's disease, particularly if the anti-amyloid therapies or antibodies are going to get approved in early to mid 2023. And this change in standard of care, or the landscape of standard of care in Alzheimer's disease, will actually affect our inclusion criteria into the prospective Nilotinib trial. So our objective is to basically include patients who are early Alzheimer's disease, who have an MMSE somewhere between 20 to 27, the early Alzheimer's disease, that will have a CDR of 0.5 to 1. These patients would be amyloid confirmed via either an amyloid PET or an LP. And these patients, of course, because we are here studying or repurposing a drug called Nilotinib for neurodegenerative diseases, and we know of its potential side effects at high doses in leukemia, like 400 or 500 milligrams a day. Here we'll be studying 150 to 200 milligrams a day based on the results of our phase 2 data. We still want to be careful about the potential side effects of the drug. So patients will have a range of QTC and of course all the classical inclusion criteria that would be needed to ascertain or to confirm the diagnosis of Alzheimer's disease, and no diagnosis or dementia is not occurring as a result of other neurodegenerative diseases, but Alzheimer's disease. So if let's say Lecanemab gets approved early next year, then our task will be a little easier, because then we want to include all the patients who are on Lecanemab, and we will study a low versus high dose of the drug. So we're going to study 150 versus 200 milligrams of the drug, and that's 50%, 60% lower than the dose given in leukemia versus placebo. Okay, so we are going to see that to include 3 groups. Placebo on Lecanemab, 200 milligrams on Lecanemab, 150 milligrams on Lecanemab. Okay, and we want to see if the additive effect of Nilotinib that we have shown in a small phase 2 study, that it actually reduces A beta and to a certain degree tau by autophagy. It does protect blood-brain barrier, and it does lower inflammation. If this drug is actually going to have an effect that would be additive to the effect of any of the anti-amyloid therapies that would be approved, and that would be a treatment for 1 year. If the no approval of other anti-amyloid therapies takes place in the next 6 months, of course, we will be studying the drug over 1.5 years. So our objective right now is, since anti-amyloid therapies are very highly likely to be approved, particularly Lecanemab, we'll treat patients for 1 year on high dose versus low dose versus placebo, and we will see if the drug can halt or improve cognitive impairment over 1 year of treatment in the placebo versus the drug. And also because Lecanemab or any other anti-amyloid therapies, particularly in the ApoE positive population of Alzheimer's disease, can induce edema, what we call ARIA, amyloid-related imaging abnormalities in Alzheimer's disease. The protection of Nilotinib, of the potential effects of Nilotinib on protection of the blood-brain barrier will actually be something that we will very carefully look at to see if edema of any sort can actually be counter or can be actually eliminated with the effects of Nilotinib. So that's where we are right now. Our plan for the phase 3 last year or this year in 2022 might slightly change, based on the change in standard of care of Alzheimer's disease.